Hello, and welcome to this Health Foundation webinar on putting person-centred care into practice, learning from experience. I'm delighted to be here today with you and delighted that there are so many of you watching with us. I start off by introducing just very briefly Nahid Ahmad and Holly Crelly, who are from ICF International, which is a policy and practice research organisation that has done the work that has led to the report which we are doing this webinar on today. You may have seen that Jo Ellins was due to be with us. Unfortunately, she's not well today, so I'm delighted that Holly has come to join us instead. But Jo does send her apologies, as she was very much looking forward to being a part of this. So this webinar is really looking at what we have learned over a number of years, in particular about shared decision making and self-management support, areas the Health Foundation has looked at from research and practice through a number of programs over a long time. And we really came to the realization that in doing these bits of work separately, that they're increasingly obvious that there were a number of connections between them, and we were really interested in looking more deeply about those connections. Conceptually, those connections, what's been happening in the policy realm in the United Kingdom around those, what is the evidence about commonalities or differences between them, and in particular, what works in putting them into practice. And that's really the focus of what we're looking at today, is taking that learning from the report which ICF have produced for us to look at what works in putting that into practice. So Nahid and Holly are going to be presenting to us, and then afterwards we will be picking up on your questions. So do please, as you have any questions, do type them in on the left-hand side of your screen and send them through to us. I will be picking them up, so if you see me scrolling on the iPad, it's just looking at any questions that might be coming through so that I know to ask them later. And after they finish their presentation, we'll be going into questions for the rest of the time. So, thank you very much. I'm now going to hand over to Nahid, who's going to kick us off on the webinar.
Thank you. Hi, so as Adrian said, we're focusing today on person-centred care and two specific elements within person-centred care, which are shared decision-making and self-management support. So we know that person-centred care is moving up the agenda, but what we want to focus on is how you actually do person-centred care or shared decision-making and self-management support in the NHS. So what are the things that we need to know about if we were to start thinking about implementing new practice in these areas? So what we think we would need to know is, firstly, you'd need to be really clear about what you're trying to implement. So what do we actually mean by shared decision making and self-management support? You can't implement something if you don't actually know what you mean by the terms, so that needs some careful thinking around. Secondly, you'd need to be able to understand the wider environment in which you're introducing this change. And then thirdly, you'd need to have an idea about what's already known. So what's the evidence out there about what works and what doesn't? So these are the three areas that Holly and I are going to focus on today. And I'm just going to start by taking that first question. What is it that we're actually talking about? So if we start with person-centred care then, which is the broader term, I think we've got to more of a shared understanding about what this is, and the Health Foundation in particular has done some really good work over the last 10 years to try and define what person-centred care is. So there is a consensus that person-centred care is care that's personalised, it's care that's coordinated, and that's enabling for patients, by which we mean that patients are viewed as active partners in their own healthcare rather than as passive recipients, which a more traditional model might have viewed patients as. We also agree that person-centred care is about treating patients with dignity, compassion and respect. So where do shared decision-making and self-management support fit into this then? Part of our work in the report was to try and look at how shared decision-making and self-management support have been defined. And actually this was quite challenging for us. There wasn't one agreed definition of either of these concepts. But if we were trying to take some learning from this that might be quite useful, we think the one point to make really is that in the sort of wide range of definitions, there are two different ways of looking at the concept. So you can look at them very narrowly, or you can look at them more broadly. So by a narrow definition, what we mean is a definition that's focusing more on the individual and the individual's behaviours. What that tends to mean in practice is that the intervention becomes quite focused on the completion of tasks. Whereas a broader definition includes more of a holistic view of the patient. So it's looking at the connections of the patient to their social environment, for example. And interventions which start from this understanding tend to take a more relationship-focused approach. So, for example, how does the relationship between the healthcare professional and the patient need to change? What is it about that relationship that makes collaborative care? Now, we think it's quite important that we think about how we define these concepts. What's quite dominant out there in terms of how interventions and programs are designed is taking quite a narrow definition, so basing an implementation in that individually focused meaning of both shared decision making and staff management support. So the problems that we might run into here are that interventions that are starting with that basis tend to focus much more on introducing tools and techniques, and also on equipping and skilling up patients, often with either an explicit or an implicit aim to try and improve compliance to medical regimes. So rather than focusing on enabling patients, that tends to be the underlying goal. It's also quite important because when you're taking a narrow definition, some of the outcomes you're looking at aren't defined by the patients themselves. So you're looking at health-related or system-defined outcomes rather than outcomes which the patient is actually interested in, the sort of goals that they might want to look at sort of trying to achieve. So it's really important then in terms of setting out to design a new intervention to first look at what it is we actually mean by the two concepts. What we also tried to do in the report, which Adrian alluded to when he was introducing this, was to look at the connections between shared decision making and self-management support and to think about the relationship between them, how similar they might be or how different they are. And we came up with several relationships, several ways in which they might be linked. But the one that we found most evidence for and the one that really seemed to resonate with people that we spoke to was to consider these two concepts as concepts which are within the broader concept of patient-centeredness. So self-management support and shared decision-making as particular elements of patient-centered care. So the diagram that you're looking at now is just a summary of this relationship. And it also has care and support planning alongside shared decision-making and self-management support. And care and support planning is another sort of concept process which is coming to the fore in recent years in patient-centred care. So the important point I think I wanted to make is if we think about what this looks like in practice, it's not so straightforward as this conceptual map shows in the diagram. When we spoke to clinicians, they told us that actually shared decision-making and self-management support can be quite fluid within a general relationship that they might have with a patient. So, for example, shared decision-making can lead to self-management support and vice versa, and they weave in and out of interactions rather than as being very static components that we can, sort of really look at like that. So there's probably a bit more work, I think, that needs to be done in terms of research to look at the connections between shared decision-making and self-management support. The diagram that you're looking at, for example, doesn't show much about that, and that's an area which we'd still like to know a bit more about. So I've talked through a bit about why it's important to look at the meanings of these concepts, and I'm going to pass to Holly now, who's going to talk more about the wider environment and what that looks like, and also start us off thinking about what it is that actually works.
Hi, yeah. So as Naheed mentioned, I'm going to talk a little bit about the sort of wider NHS and policy context for these sorts of interventions. So broadly speaking, if you look at NHS policy in the area of person-centred care, you can see sort of two main drivers or two main motivators which are driving change. So the one case that's often made is an ethical case. So this really emphasises that person-centred care is the right thing to do. It says it's right that patients should be involved in decisions about their care, that healthcare professionals should take into account people's values, people's needs, people's preferences. And we often see this framed in the policy literature as nothing about me without me. And you can see that in very current policy documents such as the NHS Constitution or the 5-year forward plan. There's also a second case that's often made quite frequently, and this is more of an instrumental case. And this really emphasises the outcomes that such programmes can have. It sees the benefits and emphasises the benefits of such programmes for patients, but also for clinicians and for services. And it really frames it in terms of some of the big challenges that the NHS is facing. So, for example, the shift from more acute episodes of care to dealing with people who have multiple chronic conditions on a much more ongoing basis. And of course, within these challenges, the biggest one that's often mentioned is the financial context and the financial challenges. And this really presents an opportunity for self-management support and shared decision-making to be seen as a way to manage demand for services or to make people's use of service a bit more efficient. And this can really be quite a powerful hook for people trying to implement a programme to use with commissioners. However, there's some issues with viewing self-management and shared decision-making in this way, and I just want to pick up on a couple here. So the first one really is there's actually quite mixed evidence that these sorts of programmes result in savings. So, for example, one of the programmes we looked at in our report was the National Cancer Survivorship Initiative, and in that they found that self-management consultations took twice as long as those that didn't involve it. Similarly, if you take a programme like Co-Creating Health, you'll see that some projects within that programme showed improvements in service utilisation, but others didn't really. It's quite a complex thing to measure, and it's quite complex outcomes. The second point I want to make is about a risk in terms of emphasising the wrong sorts of outcomes, and this might be something quite interesting to hear your views on. If we focus too much on cost savings, are we moving away from that ethical drive of care, moving away from that emphasis on patient experience, on patient empowerment? Again, something perhaps to pick up later. And I want to move on a little bit to talk a bit about what works in implementing programmes, and indeed what doesn't. So in our report, we reviewed 11 major programmes in the NHS, some funded by the Health Foundation, some funded not by the Health Foundation. And these went right through from some of the earliest programmes like the Expert Patient Programme through to really current ones like People Powered Health. And one of the key bits of learning that came out of all of these programmes, particularly the more recent ones, was the importance of having an integrated whole system approach to change. So it's not enough just to teach patients to self-manage or to share in decisions. You have to also act at the level of the clinician and at the level of the system. And several recent programmes, notably Year of Care and Co-Creating Health, have come up with some quite good models sort of illustrating this. So you'll see on your screens now the House of Care and also Co-Creating Health's White Light approach. I don't want to go into these in too much detail now, but I'm just going to pick out a couple of interesting points about them. So first of all, the importance of clinicians. It's often not really realised that clinicians face a lot of barriers to engaging in these sorts of programmes. So these can be both conceptual and quite practical. So conceptually, a lot of clinicians already think they're practising in a way. They're already sharing in decisions, they're already engaging their patients. They also often think that maybe their patients aren't able to self-manage their conditions, or they aren't able to share in decisions. And practically speaking, often they just lack time. If clinicians are very busy, they lack the headspace to think about working in a new and innovative way. So it's really important for programmes that they go beyond just raising awareness or telling clinicians about a given programme and actually actively train and engage them in the concepts. The other point I want to talk about is commissioning. So this was often cited in our research as a barrier to implementing these sorts of programmes. For example, the sort of year-long cycle of commissioning arrangements really acting as a barrier towards longer-term outcomes. Whereas actually, in reality, you can have quite incentivising commissioning arrangements. For example, they use that in Year of Care. And the key thing the key point we made about commissioning arrangements is, yes, they can help to drive change, but they don't cause it alone. They have to be as part of a wider system. And now I'm going to hand over to Naheed, who's going to talk a little bit more about some more of the key learning we found in the programme review.
Yeah, so the programmes that we reviewed were actually quite varied and quite complex, some of them with multiple interventions in them. However, we were able to draw out some common learning from across them. And in the report, we mentioned 12 lessons that were learned from the programmes review that we did. So you can see the full list there, but I just want to talk about a few of them in more detail today. And these are the ones which really resonated well with people that we spoke to. So we went through our findings in a seminar with a range of people. So we had healthcare professionals there, we had policymakers, we had educators, and we had researchers. And these ones that I'll talk about today are the ones which really resonated with them from what they know in their own experience. So the first really powerful message which people got from our report is that tools alone are not enough. They need to be embedded in a wider context where the relationship is the focus. So they won't work alone. They can't contribute to collaborative care just on their own without having that context of understanding how the roles and responsibilities of the healthcare professional and the patient need to change. You can, for example, have a tool which doesn't even need any interaction between a healthcare professional and a patient. So if we take an example of a decision aid that's very, very detailed, a patient can probably take that away, make the decision, read all about the different options, the risks, and the things that are good about those options in their own home, make a decision, come back in with this tool to see their healthcare professional with their decision that's already sort of made. That doesn't mean that shared decision making has taken place. It doesn't mean that there's been a collaborative care interaction between the healthcare professional and the patient. So tools are good, but they need to be used as a support for that collaborative relationship rather than as a substitute for it. As one of our interviewees put it, you also need that human touch. So another lesson that people thought was really important was the one to train whole teams and not just individuals. And this was some key learning which one of the programs, the Health Foundation programs, Co-Creating Health, came across, just as an example. So in their sort of phase one, they found that healthcare professionals were often trained individually. And then these healthcare professionals found it quite challenging to try and implement change in routine practice because they didn't have that wider support. So this was then addressed in phase two of the programme. Another example from the review where this was done really well was from Year of Care, one of the projects in Year of Care which ran in Tower Hamlets with the Bengali population, trained whole teams, but those whole teams weren't just different healthcare professionals. They also trained advocates for patients. They also trained translators. So obviously this approach is good because it's training everybody that's involved, but I also think it does something more than that. It adds to a culture, a shared sort of understanding, an ethos where everybody feels like they're part of this change and everybody can sort of get on board with it. So it helps with that momentum and motivation. And then another lesson which I want to talk about today, because I think it's really important in terms of showing us how we can look at patients more holistically, is for healthcare services to work with the voluntary and community sector more. So if healthcare is interacting more or integrating more with the voluntary and community sector, the view of the patient becomes more holistic. We're not just looking at a patient as somebody with a specific clinical disease. we're taking into account other needs. We're taking into account the social, the psychological needs of the person. An example from the programme review of where this was done quite well comes from Nesta's programme, which was People-Powered Health, where they used social prescribing to integrate a care and support planning approach into general practice. And they used link workers for this as well. So it was the link worker who had the really sort of detailed knowledge of what services were available in the community. But the idea was that alongside their medical prescription, or maybe even instead of it, patients could be referred on to other sorts of services which could really vary. So it might be joining a gym, it might be joining a reading group, it might be to take up a different sort of hobby. So this then begins to see the patient in a more holistic way. If we think about it, the interaction that a patient has with healthcare services is really, really minute compared to the interactions that they have with the rest of society when they're just living their usual sort of normal everyday life in the community. And then one final lesson which is really important, I think, to note is sustainability. And not only to think of sustainability at the end of a project or programme, which is something that often happens, but to think about it from the beginning, so to think about it from the outset. And a part of sustainability is to think about gathering evidence throughout the implementation of a new project or intervention. So I'm going to pass back to Holly, actually, who's going to talk to us more about the importance of evidence gathering.
Yeah, so I'm just going to talk very briefly a little bit about evaluation. I think the key point we want to make here is that evaluation isn't just about summing up what you've learned at the end of a project. It can also be used during a project to really drive and sustain change. So, for example, measurement in itself can really motivate people to work in a different way. Similarly, if you can feed back as you're ongoing some positive results, you can really help to sort of embed behaviour change with both clinicians and also patients. The other thing I think we want to mention is that when you're thinking about what's important in a programme, you need to incorporate different views of what success looks like. So it needs to be success at the level of patient, success at the level of clinician, and success at the level of the system. You also need to think not just what your organisation or the programme team wants to see, but also what external bodies, for example commissioners, are going to be looking for. You know, if you want that programme sustained, what are they going to need to see? But of course, this need to measure lots of things has to be balanced against the fact that you don't want to be overly burdensome. It's much better to robustly measure just a small number of outcomes small number of outcomes that are appropriate and measured well, rather than, take a scattergun approach and try and measure lots of things. I'm going to pass back to Naheed now just to sum up the learning from today.
Yeah, so we had to think about some of the take-home messages that we'd really want you to remember from today's webinar. And we came up with 3 key messages which we think are integral to what we're trying to say today. And the first one is that shared decision-making and self-management support are really important for delivering person-centred care. And that's person-centred care which is collaborative. The second thing is that it's actually really important how we define shared decision-making and self-management support, because our understanding of what these concepts are actually has real implications for how we practice them. And then finally, if we look at the learning that came from the programme review, one of the most important nuggets, I think, was that tools alone are not enough. And the reason this is important is because this is often the approach that's taken when implementing a new practice. So tools really need to be considered as part of the wider practice that they're embedded in. And they need to be embedded in the whole system approach, which Holly took us through earlier. And they need to emphasise the type of relationships that healthcare professionals and patients have. And that needs to be the sort of key focus. So that's the messages which we'd like to leave you with. And that's the end of the formal part of the presentation. So I'll pass back to you, Adrian.
Thank you very much, Naheed. Thank you very much, Holly, for a brilliant, succinct oversight of a huge amount of learning, in fact, because I don't think we should underestimate the breadth of what you've just covered in terms of thinking about the context, the concepts, what the evidence is telling us, and actually what really turns that evidence into practice. So can I just encourage you now that you, as you have a moment upon what you've heard, to do please send through any questions that you have. I'm just going to kick off and with some of the questions that are coming through, but I'm just going to kick off just with one general one really, which is, in doing this research and looking across there, I just wondered if there was anything that surprised you in what you found in doing this.
Yeah, shall I start? I think for me, the biggest surprise was, so whenever you start a piece of research, as a researcher, you want a definition, because that sort of makes you feel grounded and you know where you are with it. And the real surprise for me was just the diversity in terms of how both of these concepts have been defined, and the fact that there was no, there's been a proliferation of terms that are related to these sorts of concepts, but there's no sort of agreed definition that you can just go to and say, okay, so this is the thing we're looking at. And that actually created some practical challenges for us as well, because obviously we were trying to review how these had been put into practice, whereas our starting point was we still weren't quite sure how to define the terms, which is why, we went through quite a detailed description of some of the differences and then the implications of each of those, just because there was, such a range in terms of how they were looked at.
Yeah, and I think I'd echo really what Naheed says. So I led the sort of evidence, the external academic review part of the report, and the thing I found quite challenging was so many different things as self-management and shared decision making. When we were looking to draw out, what is the impact of these sorts of programs on self-efficacy or on clinical outcomes, one program was handing someone a leaflet and another was an integrated clinician training, system training, hugely diverse and quite challenging.
So you're not always, I mean that wasn't the aim, but you're not always comparing like for like. Yeah. That's not necessarily a problem, because we were looking at, the learning that was generated, but it does make it quite challenging, doesn't it?
Yeah. You remind me that a bit of research that fed into the work you're doing on shared decision making. I just recall one element in there where it said that it looked at a meta-analysis of, I think it was 75 RCTs, and that 25% of that had either not defined shared decision making or used a standard definition. Yeah. And I think there really is, it's incumbent upon all of us that when we're doing this, that we're very clear at defining what it is that we're doing, what our interventions are, and to really be thinking about what's the kind of our theory of change behind that, how that intervention is going to impact upon change. And so as we go forward from that, I think it's a really important message to take out from that. I just wanted to then come on to, one of the things you were talking about was the how different people see the value, kind of an ethical value or an instrumental value. And one of the questions that's come in is recognising and accepting that challenge that shared decision making and self-management may not be the silver bullet that is going to save the health service money or solve all its financial woes. What do you think needs to be done to support healthcare professionals in that change, so that to find that balance between, I think you spoke about it being a hook as a way to go in, but the hook can become almost a rope to lynch yourself with.
It's a difficult one, isn't it? So often, even in some of our other research, and we evaluate a lot of these sorts of programs, we often find that healthcare professionals are in a bit of a dilemma. So when you speak to people on the ground, they absolutely know why they're doing it, and it's to improve patient care, to make that experience better. But then they're faced with a dilemma, aren't they, but nothing will happen, is what they think and what they say, without having those sorts of levers, to convince boards that this is really important because it will save money. But in terms of supporting them in this sort of change, I guess what's needed is to acknowledge first, where they're coming from, to acknowledge that there is this dilemma. The fact that the NHS is so strapped for cash, that's not going away for a good few years. But I guess it's about having more of, a holistic argument for this, not just focusing solely on cost savings. I mean, and cost savings is probably a bit of a red herring as well. As Holly was saying, there's not necessarily the research to support that, you can make savings. Maybe it's more about shifting that to thinking about more efficient use of resources, in the sense of, where should we be spending this money? Where is it more useful? But yeah, it's about sort of not letting go of the patient experience part of the outcomes, and the fact, going back to those values of person-centred care, the fact that this is about enabling patients, and just keeping that at the forefront as well.
Yeah, I mean, if I may just add to that, I mean, I think one of the really important things here is about redefining value, because actually we have a health service that spends £100 billion a year. It's I got my figures right anyway. It's a lot of money, but I guess the question for me is, are we doing something that is of value to the person receiving that service? And unless we understand the patient or user of services preferences, unless we're responding to those, we might be doing very good or not so well at delivering certain outcomes. But those outcomes aren't necessarily the outcomes that are of value to the people using the service, then perhaps we're not spending our money wisely. So I just wonder if a part of this argument and conversation that we have with people, the healthcare professionals and others have within the commissioning framework, is that if we're spending this money, then let's spend it on something that is of value and delivers the outcomes that people want, rather than necessarily the outcomes that we perceive and think people want. So I just wonder, that might be one
element. Often those sort of outcomes are thought of as fluffy, aren't they? Sort of fluffy outcomes, almost sort of reducing the value of them in a way to, proper hard evidence. But I think it's really important to know that actually those sorts of things are really important, because they determine how patients, service users utilise healthcare. They have a very real impact in terms of how, for example, they do engage in self-management behaviours. If they have a very negative experience of a healthcare professional or a particular service, then that can have real implications, which can always lead you back to the cost argument anyway, I think.
Yeah, I can think of one example from I think it's Co-Creating Health, which talks about how there was a man with pneumonia, and he had an unplanned hospital admission, and so from the outside you're just measuring use of hospital services, not a great saving there. But actually what was important was the relational change that had happened because of the programme, and that he felt confident ringing up his GP, and when he was feeling a bit ill, ringing up his GP and chatting through it on the phone. And the GP had the confidence in him that he could also do that over the phone. So it's more subtle, relational, how I feel about the healthcare system, rather than simply how much I use it.
Yeah. And sorry, just on these all anecdotes in a way, aren't they? But a story told to me by someone else of a woman who needed knee surgery, who the clinical optimal outcome was to have knee surgery. Unfortunately, as an elderly woman who was a widow, she was the main thing in her life that gave her value was going to mass at church. And as a consequence of the operation, although she was more mobile, she was no longer able to kneel. So clinically, the outcome was very successful. So you could say that was a very valuable outcome. But from the person's experience, because we hadn't ascertained that, it was far less valuable. So I think it's back to the value for money. I think for people interested in a kind of very good monograph published by the King's Fund a couple of years ago, looking at shared decision-making, in particular, called Patients' Preferences Matter, by Al Mully et al. It kind of really explores how to get into preferences to define value in the healthcare system. So I'm going to move on to some other questions which are coming through. There's been a few questions coming through about health literacy and the relationship between health literacy and shared decision-making and self-management support. And so I just wondered if you had any reflections on the relationship between health literacy and it might be worth, if you want to, one of us might just say a little bit about defining what health literacy is.
You're offering.
We having had Richard Osborne, who's leading to give a lecture at the Health Foundation the other week, I think health literacy is a term that is also evolving over time. It's back to the point you were talking about, definitions. That health literacy has often been historically seen as a functional term. Is the person able to read and understand the information before them? Which begs many questions, but is now increasingly being defined in a way which I would say is much closer to kind of notions of activation. Yeah. Does the patient have the knowledge, skills, confidence and motivation to use information and to use health services effectively? So do they really have the knowledge, skills, motivation to use health services? And I guess we could tie that in with the question of activation, which is quite similar.
I mean, this is something that we talk about in the report actually, and it is really important. And the reason it's important is because it's telling us that patients are different. One size is not going to fit all. And it's also telling us about access to some of the dominant models which sort of prevail in self-management support in particular, which is, the group-based model, which might not necessarily be appropriate for all kinds of patients. Some of the programs that we reviewed were, some of the more recent interventions are looking much more closely at tailoring, and tailoring to particular groups. And that seems to, because traditionally there are certain groups who haven't accessed some of these dominant model services. But when services are tailored for a particular population, and just tailored in sort of very subtle ways, it's not necessarily about having completely bespoke services for different groups, but just that sort of small bits of tailoring seem to be really effective in making services more accessible for some groups. And the other thing is to have variation. So one of the lessons that came out was to sort of have a diverse range, almost a suite of options for self-management support or shared decision making.
Yeah, I would add to that. I think variation was something that came out as really key. Not everyone wants to go and sit in a group setting and talk about their problems. The other thing that comes out and health literacy can really help with is as an assessment tool to know how ready people are to self-manage, and therefore engage them in sort of preparation work. So, for example, they did this quite a lot in Year of Care. So understanding, what level do people need to be brought up to be able to engage in care planning, and then it can form a really useful tool, I think, for that.
Fantastic, great. So there's lots more questions coming in, so I'll try and move on and cover a few. We've spoken a little bit about kind of value to the system in a way, thinking about the kind of the house or the kind of three circles. You had the kind of the service user population, the health profession population, and the kind of commissioning provider population in many ways. So some of the questions are coming in about the health care professional, the right-hand wall of the house, if you like. And I think, Holly, you mentioned that one of the barriers was a kind of reluctance. And so some questions coming in about what we've learned about how to overcome, how to support clinicians on that journey to change in working differently with patients.
I think there's quite a lot of evidence now coming out about how best to do that. One of the key bits of learning that I picked up was the importance of peer-to-peer communication. That really, if you're going to train clinicians, it needs to be other clinicians offering that training, because A, they understand the context and they understand the issues people are likely to face in implementing it, but they're speaking from a point of respect already, and understanding and a similar cultural background. So I think that's the really key thing from me.
Yeah, that's absolutely what I would have said. It's about the way that training is delivered, and really sort of thinking that through, so that it's not patronising, it's not coming from, an out group, it's coming from one of their own almost, and just that person will understand, and they can. Some of the really powerful things in training that we were told about in some of the interviews that we did was when a clinician, healthcare professional, has talked through their own journey about, well, this is where I was, and this was my light bulb moment, and this is what I'm doing now. So that kind of really resonates with people, I think.
Yeah.
And I think, for me, there's a really interesting question here about the kind of take self-management support. What we're saying is start with people where they are, set their agenda, and help them understand their goals of change. And perhaps when approaching healthcare professionals, it's also about starting where people are at. So I recall that one of the key things that came out of the Magic Shared Decision Making Programme was where they went along with the training for healthcare professionals, and they started off with an offer of, here's training to help you work in shared decision making. And the response they got was the kind of, like, we're doing it already. And so they changed their kind of marketing approach, which was, it's fantastic that you're doing shared decision making already. We can help you do it better. And this was the hook that got people in. And again, just to reflect on some learning from some work in Cambridge on co-creating health, that once healthcare professionals had been through a programme, so it's really key about getting that hook to get them in, was they actually said they did a pre-programme of that course evaluation and a post-course evaluation, and they said, in the post-course evaluation, there's a problem. We were asked about how confident we were about self-supporting self-management. We scored ourselves really highly at the beginning. We now realise, now we know what it really means and what it's really about, that we want to go and score ourselves lower than before. So I think it's getting the hook and then starting with people at, as you say, that peer-to-peer where it's coming from within the messenger, I think is really, really, really helpful. So another kind of question that rose, and I think it was, you were talking about the whole system. But you also spoke about, what we looked at in your work, was 11 kind of programs that were demonstrators, laboratories looking at how to do this. But I guess for many people now, it's about moving beyond the laboratory and moving into wide-scale practice. So what advice do you have for people to, if you like, first taking the benefits, as you're describing, of make sure you've got sustainability built in, make sure you're doing evaluation, to avoid the pitfalls of being caught up in projectivitis, that it's a kind of 2-year funded thing and at the end of it. So what have we learned about how to get that? I guess it's the sustainability, get beyond the project.
I think you almost have to start with first principles. Why are you doing it? What's important to you? What are your goals? And then the other thing that seemed to come out from the learning was that incremental change is actually more successful than just trying to do everything at the same time. So although we're talking about whole systems approaches and, they are probably the best way to do it, you probably need to start smaller, and then as the momentum builds up, you can add the walls and add the roof and that sort of thing. But as long as you've got those sort of fundamental things, you're very clear about what you mean about the concepts, you're very clear about what your goals are, then I think the rest of the learning will sort of come into that as you progress with it.
I would also emphasise that the slide I talked about evidence and evaluation, if you have ongoing mechanism which are collecting the successes of these programmes, and you can keep feeding that back to clinicians and also to commissioners and whatever else, saying this is working, this is doing well, that will in and of itself sort of keep sustaining change.
There was a really nice point that you made actually on that slide, which is about the fact that measurement is taking place acts as a motivation in itself, doesn't it? Because healthcare professionals, quite like that sort of competitive edge of where they're scoring on something, and it can motivate them to get a better score next time.
So perhaps, Jen, just taking on that point of measurement, because again, there've been a few questions coming in around how do we know we're doing this? How do we know we're being successful? What should we be measuring?
That's a difficult question. We talk about it quite a lot in the report about the challenges of measuring at all levels, at patient, at clinician, at system. It's challenging. There are a range of tools you can use, for example, things like the patient activation measure, things like the HiQ, which can be useful as a sort of before and after measure of how my patient is doing. But I think the key thing is really to take lots of viewpoints, particularly something like shared decision making, because as we've mentioned multiple times, a clinician may think they're doing it, but a patient might not. And likewise, a patient may think they've had this wonderful, they've shared in decisions, they've really engaged in their care plan, and the clinician may walk away and say, oh, they haven't really done anything at all. So I'd emphasise the importance of multiple perspectives. I'd also suggest, you need a more long-term perspective. Quite a lot of the studies we looked at tend to stop at the end of the programme. There's quite limited follow-up work, and there's really scope there to understand how self-management, how behaviour change continues sort of 6 months, 12 months after you've finished engaging with the programme.
Fantastic. So there was some work the Health Foundation has done in the last year, so too late to really inform the primary research that you did. So people might be interested in a publication we put out earlier in the year called Helping Measure Person-Centred Care, which is a kind of rapid evidence review over the kind of measures, but also collates, it's available on the web and includes a downloadable spreadsheet, which basically has the many hundreds of measures that kind of could come into this in some way and are used, but you can search it for those that are relevant to your context, primary care, secondary care, where they've been validated, what populations they've been used on. So that might be a useful resource for people who are looking at it.
And we probably, from our experience of doing this work, advise caution on that so that you don't go mad and think, wow, we've got all these measures. You really need to think about what it is you're trying to achieve, what's practical for you to collect data on, and just maybe pick a few that are really important to start with.
Yes, I think the key thing is measure something, but don't worry about measuring everything.
Yeah.
And the other thing I'd mention is a thought paper by Alf Collins on measuring what really matters, which starts to try and set out a framework for helping us think, exactly coming back to, well, conceptually, what does it mean? Helps to set out a framework that now needs to be populated and further challenged and tested and thought through. But in measuring what really matters begins to set out an approach to that kind of exactly that question you're asking. And it's certainly a question I think we recognise needs a lot more work to be done on it, which we'll be hopefully pursuing over the next year. Sorry, Holly.
Yeah, I think it's particularly interesting for things like clinical outcomes. I know you were talking earlier about valuing what patients value, and clinical outcome measures that are used in measuring the success of these programmes are often just the clinical measures that clinicians use to measure, your biomedical progress. They're not actually measuring what patients necessarily value. So I know in stroke care it tends to be about sort of some sort of physical measures, when actually that's not necessarily what, if a patient's really engaging with their care, not necessarily what they're aiming for. So you need to make sure that those clinical measures are what patients value, not just what you already collect, I suppose.
And that leads to one other tool that's again quite recent and just kind of emerging, which is called Collaborate, which again I think was kind of quite emergent over the last year, which is a 3-question survey, if you like, measure of whether people were involved in decisions about their healthcare. And I think that then comes to actually you've got to kind of, are people getting the outcomes that they want? And you talk in your report about outcome stars, which I think are quite interesting as a way of thinking about the domains in which people can get outcomes. And secondly, measures that can help you assess process-wise, actually is our process likely to lead to that outcome? Are we involving people? And I just want to take us on now to there have been a few questions about different population groups, if you like, and around shared decision-making and self-management support, particularly around shared decision-making. So some questions coming in, just curious about shared decision-making with people with learning disabilities, shared decision-making at end of life, shared decision-making in child and adolescent mental health services. So thinking about different populations, I think people are curious as to whether these approaches work and whether there are any differences in them in different populations.
I mean, I would go back to some of the points that we've made earlier, which is that some of these groups might need a bit more thinking about in terms of tailoring, and your starting point for that would be, what's important to them, where are they? I mean, you were talking about sort of starting with healthcare professionals, but it's the same with patients, sort of starting at where they are. And I think the other really important point to make is I've not actually personally seen self-management support or shared decision-making projects or programs on any of those groups, but I think it's really important to say that I wouldn't rule out any group. You do often see in the literature that because everything's framed within something that's very narrow, looking at particular outcomes, certain conditions, for example, might get ruled out as these aren't appropriate for this sort of self-management support intervention. But I would say it's more about going back to think about how you can tailor that approach. I think that's what I'd say.
I'd also, on the flip side, we're talking about patients there, but also think about clinicians in different settings. Mm-hmm. So some of the things that came out of the research is some clinicians are more used to working in a kind of shared decision-making way than others. Mm-hmm. So particularly actually mentioned those that work with children and adolescents are used to having to take a more engaged, more collaborative approach. So think about the kind of barriers clinicians in different settings are also going to face.
Yeah.
And the other, sorry, I just wanted to add, I'm thinking about end-of-life care in particular, because that's another area that I've worked in. If you take a more broader definition of what shared decision making is, so it's more about that collaborative relationship, then you can see other interventions which might fall into this. So, for example, the care planning approach has been used a lot to talk to patients about end of life care, and their sort of preferences around that. So that can begin to look like shared decision making. Shared decision making isn't just these very sort of not simple, but more sort of concrete decisions, when there are a set number of options to choose from. It sort of should go through all types of care, I think.
Absolutely, and I think that end of life, just an example someone again was sharing with me the other day, was where someone who was nearing the end of the life wanted to say goodbye to their horse.
Oh yes, I saw that on the news.
Yeah, I think that's where they picked up in this area. And so I think it was the hospital, but I didn't see the article, facilitated them, brought that into the grounds so that they could say goodbye to it. And it's really kind of, that's kind of getting the person involved in it. And just say on the CAMS, which child and adolescent mental health, which is another area. Again, there was, because obviously I think it's amazing you looked across 11 demonstrator programs, which had a number more projects within them than just 11. I mean, I don't know how many you looked at, probably 30 or 40. Quite extraordinary. Obviously, there are others as well. But, so one that wasn't in the scope of your work was around shared decision making in CAMS, which is a Closing the Gap project. And again, it's anecdote, but one of the things I found very interesting, they worked across from community settings to forensic settings, and in a forensic setting where they introduce shared decision making with young people detained under the Mental Health Act. So the sort of population that people would intuitively say it's not going to work there. Anecdote, it led to a reduction of violence on the ward. And I think it's really powerful to think, and there's another project going on at the moment that's looking at self-management support with people with mild cognitive impairment and early stages of dementia. And again, I think it's a sign of maturity that we're beginning to recognise that actually these approaches can work appropriately in different populations.
Yeah, I mean, often thinking back to your example about the adolescents and mental health, a lot of the issues that people are grappling with in these situations are often around control and control of what's happening to them. So just giving that small amount of control back to them, can have really good effects, I would say.
Yeah. So I'm just going to take us on to possibly the last batch of questions, looking at the time. There have been a few questions coming in about the types of interventions. So we're talking about what works here. We've spoken a bit about different populations, and we've spoken about self-management. You've looked at interventions such as training for patients. We've spoken about, we looked at peer support. I think that people are curious about what sort of interventions work in what sort of circumstances.
Oh, that's quite a detailed question. I don't think that it's well covered in the report. There's so many sort of nuances in there as well, you see. And I think I'd go back to, again, the key learning is to offer a range, because you can never find one that's going to be right for everybody. People might vary by, their particular group that they're in, whether that's based on ethnicity, type of condition. But then again, people vary from person to person in terms of what their own preferences are, where they're at with their health condition, or just generally in terms of how ready they are to have that sort of active role.
Yeah, and I think I'd say that it's not as simple as saying that this particular technique works. So even if you take one technique, say motivational interviewing, which we've got quite good evidence for, that can be offered by lay health coaches, it can be offered by clinicians as part of in a GP surgery, it can be offered by nurses, in all sorts of different ways. And so it's not quite as simple as saying this works particularly well.
And again, I think this is a kind of the next stage of emerging work to be done in many ways, which is looking at roles So many of the projects and programs, as you describe, have looked at the roles of healthcare professionals and have looked at the role of the patient. And some of the programs have begun to look at, and you were talking about the role of the translator and link workers, and care navigators, and health coaches from outside of the health system, and the role of voluntary and community sector. And I think that there's more for us to do in really understanding that range of roles and thinking about what are the relative complementary roles that different players can take in supporting people so that they feel able to make their decisions that are right for their lives and to manage their health and healthcare in a way that meets their own goals.
I mean, I'd agree with that completely, because there are, and we talk about it in the report, there are sort of tools that are well regarded by people. So there were, we did ask that question, and there were a few that came up. Motivational interviewing was one of them, sort of goal setting, and care planning was another. But I think I'd be sort of quite cautious about saying that these are the ones that really work, because of all the reasons that you just mentioned. And also things become sort of come in and out of fashion as well, and become popular.
And also remind me again, it's only a part of this in an earlier report on helping people help themselves. There's a nice little, I think, 2x2 matrix. There's little things that you have which looks at different dimensions of what you're trying to achieve, because actually I think the tools and approaches you use will depend upon the goals that you're trying to achieve. And actually you're talking about motivational interviewing and group education are effective in certain domains. Information, if your goal is just to gain knowledge, is relevant in other domains. So it's also thinking about the purposes that we're trying to achieve with the intervention. So we're coming towards the end of our time now. I start off first of all by saying a huge thank you to Nahid and to Holly for taking us through the highlights of the report, and also so comprehensively addressing some of the questions that have been coming in. For those questions which we have not had time to cover, I take full responsibility. I apologise if we haven't managed to address your question directly. There is the full report, which there is a link on your screens to that. There's also a shorter learning report just based upon that, thinking about directly implementation in practice. And there's also, which I think we'll come to again, some of the questions we haven't had time to get to, an in brief, which looks at the implications of this for the kind of big system players, if you like, the Health Education England or CQC or NICE, etc., which I know there were some questions coming in about and how they play their role. So there's something we've put out there which suggests what we think needs to happen in those areas and those domains. So I think it's been really, really rich conversation. Thank you very much for the questions. What are my take-homes from this? It's very difficult to sum up in 30 seconds because it's so rich, but I think I'd come back to what you summarised before, Nahid, is that we need to think about this from the whole system perspective. We need to recognise that this is about relationships. We need to recognise that tools aren't enough, and we need to think about the roles of different players within the system and outside in the voluntary and community sectors as well, and how we all come together in the different roles and relationships. So thank you all very much. Thank you for joining and participating with us. There will be, this is a webinar in a series which the Health Foundation will be continuing to run. The next webinar is on the 16th of December, I believe. So please look out on our website for information about the webinars that are coming up, to see those that will be of most interest to you. And can I just highlight that on the screen you will find a link to the report, and you will also find a link to the Health Foundation's Resource Centre, Person-Centred Care Resource Centre, where I think a number of the resources and ideas and reports that Holly and Nahid have spoken about are available, and other tools and resources to help you support you in the changes that you want to make locally. So thank you all very much, and I hope that we will continue the conversation on how do we make person-centred care the day-to-day reality in the National Health Service. Thank you.